Hey gang, Dr. Barone again. This is our second tape in our female genital pathology section. Remember, we gotta focus on tumors. Tumors get us the most points, but in the cervix, inflammation is also important as well. So we're gonna start with cervical inflammatory conditions like cervicitis, inflammation of your cervix. Now what you're gonna see here is a purulent discharge coming out of the vagina. So we'll put a speculum in, we'll look at the cervix, and it's gonna be red. It's going to be edematous. It's going to be friable. Now we often see a thick yellow-green purulent material coming out of the endocervical canal from the cervical os. Now if we do a bimanual exam and we move the cervix, oh, she's going to jump. That's pain, cervical motion tenderness. That tells me that's clearly an inflamed cervix. Now, what causes inflammation of the cervix? It's usually an STD. The two most common by far are going to be chlamydia and, of course, Neisseria gonococcus. Those are the two biggies. But urethroplasma, trichomonas, candidiasis, HPV can give you condylomata, and, of course, herpes can give you painful vesicular lesions there. Now, what about ascending? Can the inflammation keep going up in the cervix? Yeah, that's called pelvic inflammatory disease. Now, when I was in med school, they said, bro, go check room 6. She's got PID. I was like, what does PID stand for? They go, it stands for pus in there. No, it doesn't. But they're right. There's pus in the cervix going all the way up. That's pelvic inflammatory disease. Now, let's repeat. When is it pelvic? When the cervicitis ascends. Now the next place it's going to go to, so let's start here at the cervix. Next place it's going to go is to endometrium. It's going to go to the endometrium. So when it goes to the endometrium, it goes up the endocervical canal right here, endocervical canal, to the endometrial cavity. Now I'm going to get midline pain. That is called endometritis. Endometritis, inflammation endometrium, I'm going to have midline abdominal pain. Now it's going to keep ascending and it's going to the fallopian tubes. Now I'm going to have salpingitis. Now the pain is going to lateralize. It's going to go to the sides. So for midline pain, it's going to be more lateral, more adnexal. When I say adnexal, that's the ovary and fallopian tube area. So I'm going to get pain there. Then the next thing that's going to happen is it's going to go from the fallopian tube into the pelvic cavity. Now we're going to get peritonitis. Peritonitis. So this is called pelvic inflammatory disease. Starts with cervicitis. It becomes pelvic when it goes up and you get endometritis, salpingitis, and then peritonitis. Now what often happens is the infection, if it's untreated, often localizes, loculates by the liver. So up by the liver, you'll see these abscesses here. This is called a perihepatitis. Perihepatitis, inflammation, abscesses around the liver. So this person will now get right upper quadrant pain. Now this is a very classic finding. If you don't treat PID, you get peritoneal findings and then it loculates to the upper quadrant near the liver. If you put a laparoscope in and you look with the laparoscope, since the infection came from the fallopian tubes, now it's by the liver, you often see fibrous adhesions connecting the fallopian tube and the capsule of the liver. These fibrous bands, these connective tissue bands. Yeah, this gets a fancy name. When you look at the scope, it looks like violin strings. So they call it violin stringing. The name of this is Fitzhugh-Curtis. Fitzhugh-Curtis syndrome is when you get a perihepatitis. Perihepatitis, loculation of the infection in that area. And again, this violin string, I always remember, Fitzhugh-Curtis, Fitzhugh-Curtis, violin string, Fitzhugh-Curtis. This is a form of pelvic inflammatory disease where it's localized, it's loculated in the right upper quadrant. So know that term, Fitzhugh-Curtis, when you see violin stringing. And again, this is not good. It's not good to have infections in your pelvic cavity, your peritoneal cavity. Not a good thing. Pelvic inflammatory disease, you need treatment, you need antibiotics. All right, now Barbara, how's it going to heal? Scarring. It's going to scar the fallopian tube. You can get infertility. Infertility, that's a major complication of pelvic inflammatory disease. In fact, they're often asked about that. They say a woman has trouble getting pregnant. What's a major risk factor? A major risk factor, there's many, but one of the major risk factors is scarring from PID. In fact, if she does manage to get pregnant, the pregnancy often gets stuck in the fallopian tube, gets stuck there because of scarring, and you get ectopic tubal pregnancies. So that's very testable. One of the major causes of ectopic tubals is scarring from prior pelvic inflammatory disease, prior PID. So remember, pelvic inflammatory, very testable. Plus in there. Now let's move forward and talk about one of the infections called HPV. Human papillomavirus, very important. It loves the cervix. But which part? It is tropism for the transformation zone. The area we have immature squamous metaplasia. We call this the transformation zone. When a woman is young, when she's young, well, let me just show you here. In the vagina, we have squamous cells coming up to the cervix, and then in the endocervical canal, we now have glands, columnar cells and glands, columnar cells and glands. Now, when she's younger, these glands, these columnar epithelium, actually come all the way out here. They come out here. Now, as she gets older, these glands go away and become squamous, 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 squamous. So basically, it used to be glands here, then it turns to squamous. This is called the transformation zone, where it was glands, and now it turns to squamous as she gets older. So these glands kind of go in and they go hide in the endocervical canal. But this is now immature squamous cells. That's what HPV loves. It loves this transformation zone, where it used to be glands and now it's immature squamous cells. That's what HPV loves to infect the most. Now, where it actually turns from squamous cells, this is called the squamocolumnar junction. Okay? So transformation zone is this area here, which has immature squamous metaplasia. Glands turn to squamous. And then the actual junction is right there. Now, let me show you with an actual picture. This is a really nice picture. Okay, now it's kind of like turned sideways here a little bit. So here's the normal squamous lining of the vagina. Notice it's glycogenated, so there's a lot of clear spaces in here. That's a nice, healthy, glycogenated epithelium. Notice you only have dark cells at the basal layer, just the basal layer is proliferating, and as you go up, they quickly flatten out and become very clear. These are mature squamous cells of a vagina. Then I start to see squamous cells that are kind of like darker, right? These squamous cells are darker, they're more condensed together, they're not glycogenated. This is immature squamous cells. This is the transformation zone. And then finally here, we see a junction between these immature squamous cells and these tall columnar epithelium with these glands here. See this gland coming down into the, so it goes here, and it comes back up. Well, this is the endocervical cervical area, which is lined by columnar glandular cells. So this right here is the junction between squamous, immature squamous cells and the columnar cells. Now again, this immature area is what HPV loves the most. It will also infect mature cells, but it really likes this transformation zone. So remember, when you do a pap smear, you want to try to scrape this area, especially right here, very close to the junction. So I want to scrape the transformation zone next to the junction. So here's the key. When you do a pap smear, put it on the side. I want to see squamous cells, and I want to see some columnar cells. Because that told me you got close to the junction where the transformation is. You got close to the junction. If I only have squamous cells, you might have scraped over here. You didn't get where the transformation is. You didn't get where the junction is. So very important that when we do a pap smear, we try to get really in there and scrape where the transition is. Because otherwise, if you just see squamous cells, that's an inadequate pap smear. I gotta see squamous cells and some columnar cells. That's a good pap smear. That means I scrape this area where the transformation is. Okay, very important to learn that lesson. Do a pap smear, get in there good, scrape it good, and make sure when the for the specimen, and they have both cells. Okay, now cervical cancer. This is a very important cancer. It's the number 8 cause of cancer death in women. Now, it used to be number 1. In 1940, cervical cancer was a big killer in women. It went from number 1 to number 8. What happened? Prevention. Pap smears, the greatest screening test of all time for cancer. Greatest cancer screen, pap smear. Pap smear. We pick it up before it's cancer. We pick it up as dysplasia. If we pick it up as dysplasia, we treat it, you never get cancer. And now with the HPV vaccine, they're gonna laugh at you. You went into medicine when there was still cervical cancer? Oh my God, you're so old. Yeah, with the HPV vaccine and pap smears, we shouldn't see much cervical cancer. If we're gonna get the pap smears and getting the vaccines, you shouldn't see much anymore. Now, unfortunately, we still see it, but luckily it's becoming less and less common. Now, it's most common in 40s and 50s. Why? Because it takes time. First, you have to get reproductive age. Then you have to meet a couple of guys. Then you meet the rude boy. So you're like 25, you meet the rude boy. Now you get HPV. Now it takes time to go from low-grade dysplasia to intermediate to high-grade dysplasia to carcinoma in situ, and then finally invasive cancer. It takes like 10 to 15 years. So if you meet the rude boy at 25, 10 to 15 years later, you're looking at your 40s and 50s. That's usually when they come in with the invasive cancer. And again, it really depends. Nowadays, people are having sex at 12. So this is becoming younger and younger and younger. But again, it takes a long time. So that's why the pap smear is so important. It takes 10 to 15 years to go from dysplasia to cancer. So if we're screening with pap smears every so often, we should be able to diagnose this before it's invasive. Now, risk factors, well, let's see, early age of first intercourse, multiple sexual partners, a male partner with multiple previous sexual partners, cigarette smoking. Notice, sex. But it's not the sex. The sex is good. The risk factor is not the sex. It's getting HPV high-risk types. If you have early intercourse, you gotta have more intercourse. You start early. You have multiple sexual partners. If you have a male partner who's had a lot, you're sleeping with all the people he slept with before. So more promiscuous, more likely to get it. So it's not the sex. The sex is good. It's the high-risk HPV. 16, 18, 31, 33. This is the risk factor because they integrate into the host genome and they produce viral oncogenes E6 and E7. E6 knocks out p53, E7 knocks out RB. That's why these cause cancer. Now there are 2 more risk factors. Aside from HPV, cigarette smoking. I'm not so sure how the carcinogens get down in there, but don't let your vagina smoke. And then immunosuppression, because without an immune system, I can't stop the HPV. If I can't slow the HPV down, I'm going to get cancer. So these are the really 3 risk factors: HPV, smoking, and having no immune system, immunosuppression. Those are the 3 risk factors. All right, now again, know the high-risk types. Sweet 16 is very sweet, except for HPV. Sweet 16 ain't so sweet anymore. Yeah, you're doing the nasty. So 16, 18, 31, 33, these are the high-risk types. They're going to insert themselves in your genome, they're viruses, they'll insert themselves, and they'll start making viral oncogenes, E6, E7. These knock out these major tumor suppressor genes. Now, another mutation that can also occur are acquired somatic mutations in LKB1, also known as STK11. So remember, lick the stick. It's only found in 20%, but you remember it was also found in Putz Jaeger? Yeah, like Mick Jagger, lick the stick. Rolling Stones, Mick Jagger, yeah. So it was also found in Putz Jaeger as well, and sometimes it's found in lung cancer. Now again, is it super high risk for USMLE? They could ask it, but they're more likely to ask this mutation in Putz Jaeger. Putz Jaeger had the big lips like Mick Jagger with the pigment, the black pigment, and they have multiple polyps in the small intestine. They're hamartomatous. They don't lead to cancer, but they do lead to intussusception. That was on our exam. It can lead to intussusception. All right, now what else do we need to know? Well, we want to screen for this. Now I'm going to do these slides out of order. The dysplasia is what occurs first. They misnamed it. They called it cervical intraepithelial neoplasia. It's really dysplasia. But sin, ooh, you sinned. You had sex. You did the naughty. That sounds more naughty than SID. It should be cervical intraepithelial dysplasia. It should be SID. But they said sin. It's a better eponym. So they called it sin. And by the way, once they did that, now we're using this term everywhere. Prostatic intraepithelial neoplasia, pancreatic intraepithelial neoplasia, vaginal intraepithelial. We're using this everywhere. This misnomer is being carried on forever. It's really dysplasia. Now we're going to screen for it with the Pap smear first. This is the biopsy. We'll come back to it. Pap smear. Okay, Pap smear is the most successful cancer screening test ever invented. We're going to scrape the cervix, look under the microscope at cells from the transformation zone. Now, how did I know to do this? Well, we naturally screen, but of course, if you have cervical cancer, you're going to get symptoms. So you can have vaginal bleeding, usually after intercourse. Because if you have a cervical tumor, when you do intercourse, you're going to bump it, it's going to bleed. So remember, bleeding after intercourse, that's one of the ways cervical cancer presents. Another way it presents is it's a big fungating mass, it'll become necrotic. So you're going to get this malodorous discharge. You get leukorrhea, very mild necrotic tissues coming out. You can also get pain during intercourse and sometimes dysuria as well. You can actually invade into the bladder. Not cool. Now, cervical cancer should be picked up before it's ever cancer. So it's most common in women who've never had a Pap smear in at least the last 10 to 15 years. Because if you have a Pap smear, we should have picked it up. Now let's look at the Pap smear. I showed this to my niece and she's so excited. She looks so, oh, it's so pretty. Look at all these different colors. Yeah, normal squamous cells. Notice the size of the nucleus, small. Notice the size of the cytoplasm, big. So squamous cells are basically all cytoplasm, very small nuclei. Now if I do a Pap smear and I see this, notice what I'm seeing. I'm seeing the nucleus, it looks like it's actually multinucleated, but the nucleus is enlarged compared to the cytoplasm, increased nucleus-cytoplasm ratio. And if you notice in this cell, notice where you got a clearing here? You have a clearing around the nucleus. Here it's darker pink, but around the nucleus it's clear. That is coilocytosis. That's HPV. That's HPV. So when I see this on a Pap smear, clearly, these aren't normal squamous cells, right? Normal looks like this. So this is abnormal. We call this low-grade squamous intraepithelial lesion. Low-grade squamous intraepithelial lesion. That's all we can say. I see it's looking funny, and I see it clearing here. I think it's HPV, so this is low-grade. Now, what if I look and I see this? Holy, look at the size of that irregular nucleus. Oh, this is getting bad. This is high grade. Now look at these cells. Again, big nuclei, but notice I'm starting to see neutrophils here. I'm starting to see inflammation, maybe some necrotic tissue over here, some dead stuff. Ooh, this might be invasive because you're seeing inflammation, you see necrosis. So again, increased nuclear to cytoplasmic ratio. Nuclei that are kind of irregular, not round anymore, they're kind of more irregular and dark, hyperchromatic. So these are both called high-grade squamous intraepithelial lesion. So Pap smears are kind of easy to read. Either it's normal, come back and then we'll check you again next time. You're all good. Or I see low-grade dysplasia, or I see something that looks bad, high-grade. That's it. Pap smears don't give you much information, but very important. If it's abnormal, I don't care. This one, low grade or high grade, I don't care. If it's abnormal, what do you do next? Abnormal Pap smears, you must follow them up by doing colposcopy. You put a speculum in, you look at the cervix with a scope, you look in, and biopsy. So colposcopy and biopsy must be done for abnormal pap smears. If it's normal, come back when your next pap smear is scheduled. All good. If it's abnormal, either low grade or high grade, I need to look with the colposcope, put the speculum, put the scope in, and do some biopsies. Now, when we do the biopsy, it's a little bit more complicated. It's not just low grade or high grade. We got actually 3 grades now. Here's the normal glycogenated, beautiful, reproductive age squamous cells. Notice, lots of glycogen, nice and clear. Notice they're only dark though at the very bottom. See the dark cells? Those are the ones that are proliferating. That's your basal layer. Now, notice here, the cells are darker, there's more nuclei here, the nuclei are larger, and then notice these dark cells are going maybe about a third of the way up. These dark cells are streaming upwards, see the way they're going upwards? And then finally they start going across, here they're going across, going across, going across. That's kind of streaming up for about 1/3. If it's 1/3 dark cells, we call that CIN1. 1/3 abnormal cells. Now here, they're getting very dark, they're streaming up, and they only kind of flatten out up around here. So this one's probably about 2/3 of the way, 2/3. Well, that's called CIN2. When the abnormal cells are going up about 2/3, see these dark cells streaming up, and then they finally start to flatten out around here. So it's about 2/3 of the thickness. So dysplasia always starts at the bottom and moves up. So 1/3 CIN1, 2/3 CIN2. If it goes more than 2/3, like full thickness, now it's CIN3. Look at these dark cells. They're all kind of streaming up. They only flatten out at the very, very top. That's CIN3. Like it's 2/3 or more. 2/3 or more. So it's kind of easy. When I do the biopsy, I want to see, is it low-grade dysplasia, CIN1, moderate 2/3 of the way, or high grade all the way through. Make sense? Now, we have 2 key decision points. 2 key decision points. Right here. And then the next step after CIN3, it will become next carcinoma in situ. So these cells will get really ugly. They now have so many mutations, there's no way it can go back to normal. Remember, dysplasia, if your immune system kicks in, you can clear this. CIN1, 2, and 3, you can clear it. I've seen cases of CIN3. They want to do a biopsy, but she has something else going on. So 6 months later, she finally comes in for the biopsy, and we can't find it. It's gone. It's gone. So the immune system just kicked in and cleared it. So dysplasia is reversible. Once you get the carcinoma, no go back. Then the next step is invasion. Invasion. Invades through this basement membrane, goes down in, invasive. So that is your second decision point. So let's repeat. Decision point 1, decision point 2. Okay, if it's CIN1, which on a pap smear is low grade, so low grade pap smear, you do a biopsy, it's CIN1, just watch them. Watch them. Because CIN1 often goes away. It often goes away. Oh, but I forgot to mention, do you see the clear spaces around the nuclei here? This is the HPV. It's corticocytosis right there. Corticocytosis right there. That little clear space around the nucleus. So that's HPV. It usually gets cleared. So for CIN1 patients, we say we're going to repeat the pap smear. We'll follow you, but usually it's going to go away. We just observe frequent pap smears. Now let's change it. If it's CIN2, CIN3, or carcinoma in situ, well, we got to treat this. We got to treat this. So the answer is local treatment. Local treatment. So what am I going to do? I'm going to go back in there, and usually we do a cone biopsy. We remove a cone of tissue from the cervix and get it out. If you don't want to do a cone, you could do a loop curette. Just cut out with a loop or heat. You know, like that. You can laser it. You can burn it. You can freeze it. The key is local therapy. Now, once they say it's invasive, now you recommend hysterectomy. So that's a key decision point. Once it's invasive, we go from local therapy, which is like a cone biopsy, we now go to hysterectomy. Now again, whose decision is it? It's the woman. It's her body. Our job as a doctor is to recommend. We recommend. Once it's invasive, we recommend removing your uterus. What if she says, no, I have to have kids, that's the only reason I'm on earth. I need to have a kid. You say, well, we recommend hysterectomy, but if you want to have a kid, you gotta do it quick. Because those 9 months while this is gonna keep invading and getting worse. And eventually it's gonna get so bad, it's gonna make an incompetent cervix, and you may not be able to carry the pregnancy anyway. But again, it's her decision. Some people want to take the risk of that waiting 9 months and then doing the treatment. Because once you remove your uterus, there's no going back. Right? There's no uterine well, we're working on uterine transplants, by the way. But right now, it's not something that's easy to do. So unfortunately, once we take out the uterus, that's it. So we recommend hysterectomy for invasion, but it's the woman's choice. Our job is to recommend. She has to make the decision. We give her the pluses, the minuses, hear what can happen. She makes the decision with us in consultation. All right, I think you guys got this. Now let's move on and talk about what the colposcopy looks like. We're going to put a colposcope in to take a good look at the cervix. Now when I look at the cervix, notice it's a nice epithelium here, nice and thick. And then notice I see an opening here. This is the endocervical os. If I go through that, I'll go through the endocervical, the glandular area, into the uterine cavity. That's how you enter the uterus, through this central endocervical os. Go right through there. Now, what we're going to see is normal should look like this. Now I'm starting to see some lesions here. Yeah, this is probably low grade. We better biopsy that area. Now look at this stuff. Kind of hemorrhagic would lead, oh, this is looking worse. And then look at this thing. This is actually like a mass. Now, I don't care. When I see any kind of lesion on a colposcopy, I must biopsy it. Now, to help me see this stuff better, what we like to put on the cervix is acetic acid. So we'll actually put acetic acid, or just coat it with acetic acid. And what this does, it highlights abnormal areas. It makes them white. So this is kind of different than Lugol's iodine. Lugol's iodine we use in the vagina, and it makes everything white that's normal. The stuff that doesn't turn white, that stays red, is the abdominal area. So this is different. This is acetic acid. Acetic acid makes the things that are abnormal turn white. So the white stuff is what you biopsy. So here it is. Take a look at the actual patient here. Take a look in here. Here's the endocervical os. This one is more, it's kind of slit-shaped. It's not quite round. She probably had a couple pregnancies. So this is kind of a slit-shaped one. That's the endocervical os. And then notice this white stuff here. This is aceto-white epithelium. This is the area you want to biopsy. Something's abnormal here. Could be low-grade dysplasia, could be high-grade, could be cancer. These are the areas we're going to take biopsy. We'll take a bunch of biopsies from this area. Make sense? Now, another thing that I want to look for is I may see basically what's called vascular punctations, little red areas, little red dots, or maybe a mosaic pattern. This is a mosaic. See these little white areas here? Little white area, looks like a bunch of stones you're kind of fitting together. That's a mosaic. Put a bunch of stones together, that's a mosaic pattern. So I don't like seeing this. I want to see a uniform mucosa. I see vascular patterns, I see mosaic patterns, I see white aceto white areas with acetic acid. This abnormal, we gotta biopsy these areas. Make sense? So that's what it looks like on a colposcope. We'll do a biopsy and we'll see is it CIN1, CIN2, CIN3, carcinoma in situ, and then we'll make our decision as what to do next. All right, now look at this thing. If you put a colposcope in and you see this, the endocervical os is somewhere in here. I see a big, ugly, fungating exophytic tumor. I'm going to do a pap smear. If you put this pepperoni, if you see this, you go right to biopsy that. That's going to be invasive tumor. This is a woman who didn't get a pap smear. No wonder she's going to have bleeding after intercourse. When you bump that, that's going to bleed. This big fungating tumor destroying your cervix. Now, the most common type of cervical cancer is obviously going to be squamous cell. That's the most common type. There are other types, but squamous cell is most common. Now, depth of invasion is important. The deeper it goes, the more likely it is to find blood vessels. Now, in addition to squamous cells, if the tumor is up towards the endocervical canal where the glands are, you can get adenocarcinomas. So again, they're not as common. They usually come from the endocervical area. And then rarely, you can get small cell neuroendocrine tumors. Now, when I say small cell neuroendocrine, you think lung cancer. What was the prognosis for small cell lung? What's the prognosis for small cell of your cervix? Very aggressive. So this is kind of like a lung cancer of your cervix. Not a good one, small cell. Thank goodness they're very rare. So again, most of them are squamous. If it's from the endocervical area, everyone's going to get adenocarcinoma. And then very rarely you can get small cell cancers, which can metastasize very rapidly. Very aggressive, not good. All right, now treatment. For CIN1, we observe. For CIN2, 3, and carcinoma in situ, and sometimes even small microinvasive tumors. If it's just micro, it's small invasion, local therapy, cone biopsy. Once you get full-blown invasion, you gotta recommend hysterectomy with lymph node dissection. You got to have lymph node see if it's spread. Okay? So again, the key decision point is it fully invasive? And then of course CIN1. Everything in between, CIN2, CIN3, carcinoma in situ, even microinvasive, we try local therapy. Now, here's what they're gonna ask you. If you don't pick this up early, it will kill. It will kill. So how does it kill you? Well, let's see if we remember. Okay, let's make a drawing of a woman on her side, joint sideways. So in front is the bladder. Then here is the vagina with the cervix. Okay, and then of course we got the uterus and the fallopian tubes. Oh boy, that's a funny looking uterus. And then behind with the rectum. The rectum's back here. Now, if I have a big cervical invasive tumor, let's see how it's going to kill me. Let's see. If it invades up into the uterus, what? Every 24 hours, they boot you out. They boot.
Sorry about that. Looks like his connection got messed up.
Well, how many? Okay. Oops, sorry guys, I'm in a hotel and every night, every 24 hours, they boot you out. They boot you out so I got knocked out, so I had to relog in. Sorry about that. I knew it would happen around this time. Okay, so let me finish what we were saying. Cervical cancer. In front of the cervix is the bladder. Bladder's in the front. Then we have the uterus here. We have the rectum. Now, how is cervical cancer going to kill us? Well, if it invades upwards, it'll invade the uterus. So I'll get vaginal bleeding, I'll get infertility, I'll get pregnant, but not going to kill me. It invades backwards, it'll go into the rectum. I'll get constipation, I'll get obstruction, I'll get bleeding out of my rectum, but not going to kill me. What kills you is when it goes anterior. If it goes anteriorly, it's going to invade the posterior wall of the bladder. Now, if you remember, in the back of the bladder is the trigone area. That's the area where the ureters come down. Do you remember the ureters come down and they enter in the posterior? Well, when you get tumors that go anteriorly, they invade the posterior wall of your bladder here when they go front. When they block that, you're blocking the ureters. So now the urine backs up, you get hydroureter, leading to hydronephrosis, leading to renal failure. I know, it's cervical cancer, but you die of renal failure because it blocks the ureter. And a lot of students are going to miss that because we don't see much cervical cancer, so a lot of students won't know it. Again, it's not metastasis usually. Cervical cancer usually kills you from local invasion of the bladder and ureters. So I know it's cervical cancer, but you die from renal failure, from blocking those ureters. Now, if you have this tumor, you picked it up late, well, it's invading everything. Do you know what we need to do now? We have to do what's called a pelvic examination. This is the worst thing ever. Pelvic examination means I'm gonna have to take out the uterus, cervix, and part of the vagina, because it's all invaded. I'm gonna have to take out the rectum, because it's invaded. And I have to take out the bladder. I'm basically taking all of your pelvic structures out. That's called a pelvic examination. It is a nasty surgery. I've seen a bunch of these, and I feel so horrible. This poor woman, her bladder's gone, you have to make a new bladder. The uterus is gone, the rectum is gone, they have to do a pull through. It is a mess. So, always recommend, get the pap smears, pick it up as dysplasia, treat it before it ever gets invasive like this, because when it does, it's very sad thing. All right, now let me just show you the difference between microinvasion and true invasion. Microinvasion means you just get a small little area where like a few millimeters, and again, it's variable. Some people use 2, 3, 4, but it's invading a few millimeters. That's just microinvasion. Local therapy, just cone it, freeze it, get it out. But once it's fully invasive, where you see nests of keratin pearls and keratin walls invading all the way through, you need a hysterectomy. So again, that's the key decision point. Once it's fully invasive, hysterectomy. Before that, local therapy. All right, I think you guys got cervical tumors down cold, very high yield. Now the next thing we have to talk about polyps. Now there's two places we can get polyps. We can get polyps from the endocervical area, or we can get polyps from the endometrium. Now only one of these is going to be malignant, potentially. So one of these can be a tumor, very important. It's usually the endometrium. This could be endometrial adenocarcinoma. So very important, if the polyp comes from the endocervical area, I'm not worried. There's no malignant potential. Now if we take a look at this uterus, we open it, cut it in half, open it out. Down here is the cervix, Then we cut it open, so this will be the endocervical canal, going up this way, endocervical canal. This is lined by those glands. And then we got the endometrial cavity, this triangular cavity, this red area here. This is the endometrium, this cavity here. Now we notice this polyp is kind of coming, this little polyp that's sticking out here, is kind of coming from the endometrium. So this is an endometrial polyp. If the polyp was coming from here, well, that's going to be an endocervical polyp. They're always benign. I get them all the time. Endocervical polyps, no big deal. These are benign polypoid masses coming from endocervical mucosa. On gross, they're soft, smooth, glistening surface. When you cut them open, you'll see cystic spaces with mucus. No big deal. Glands and mucus. Under the microscope, you'll see mucin-secreting lining, benign glands, edematous stroma. You'll see some inflammation because it's squished in there. They may bleed. That's the significance. This is a potential cause of vaginal bleeding. So you say, what's wrong? You go in, you see this little polyp coming out of the endocervical area. Oh, remove it. Your bleeding will stop. Benign. Now again, when these tumors are coming from endometrium, that's a big difference. Polyps in the endometrium could be benign, or they could be a polypoid cancer. So for these, we have to look at them closely. Now, under the microscope, if they're benign, they're going to be composed of endometrium, which looks like the basalis, the basal layer endometrium. They tend to have small muscular arteries, so they can definitely bleed, and you'll see some dilated glands. Now, the stromal cells are going to be monoclonal and neoplastic. So really, this is a benign proliferative lesion of the stroma. It's really a stromal polyp. That's what they really are. Now, they're most common around the menopausal age, and they're going to present with abnormal, irregular vaginal bleeding. Good news is you go in, you remove them, and it's benign. But the key is you always got to look for malignancy, because there is a risk that these polyps can turn malignant, or they just may be a polypoid malignant tumor in the first place. So these are the ones that have malignant potential. Remember, endometrium potentially could be malignant. And the cervical, I'm never worried about those. All right, now, let's talk about one more lesion in the cervix. Do you remember we talked about cervicitis, and you can get a strawberry cervix? That's what it looks like. On the surface of the strawberry, you got little like seeds, right? Little dots. So it looks like. It looks like the little dots on a strawberry. These little punctate hemorrhages, hemorrhage. They call this the strawberry cervix. Trichomonas, it's tricky. This is a flagellated, it's got a flagellated protozoa. It's got corkscrew motility, so it kind of moves in a corkscrew fashion when you do a wet mouth. So you take a scraping, put it under wet, and you can see it move. It literally moves like that. Now, if you look at the clinical presentation, it's usually copious stock. I got this abundant, frothy, yellow-green or gray-green vaginal discharge. You get a lot of stuff coming out of the vagina. Now, when we do colposcopy, we'll see punctate vessels, punctate hemorrhages, and it makes it look like a strawberry appearance to the cervix. Now, for diagnosis, to confirm trichomonas, a wet mouth would work great. We could do direct musculoscopy, we could do dipstick testing, we could do nucleic acid amplification tests of the vaginal secretions to make the diagnosis as well. We could do culture, many ways to diagnose this. Now, the treatment, metronidazole. Metronidazole, very good for protozoa here. So metronidazole, and don't forget to treat their partner. Because if you don't treat their sex partner, you just treat the patient. Well, now they're having sex with their partner, they got it from their partner's got it too, now they're gonna get it again. So always treat the partner, very important, because otherwise it'll keep bouncing back. All right, now let's do some cervical pathology recall. We just did this, so it should be pretty easy. What if I have cervical motion tenderness, adnexal tenderness, so adnexal, fallopian tube, or ovary area, what's that called? Well, cervical motion tenderness is cervicitis. But then I get uterine midline pain and adnexal pain. Well, now it's in your pelvis. This is a cervicitis that is ascending. We call this pelvic inflammatory disease. Pus in there. All right, now number 2. What is the most common organism responsible for PID? Well, most common is chlamydia, closely followed by gonococcus. Very good. All right, now, what is the name of the most common site of HPV infection? It's the transitional area where you have immature squamous cells. Now, we gotta scrape that T zone, that transformation zone. So immature squamous metaplasia of the transformation zone, that's where you gotta scrape. All right, what are the high-risk types of HPV? 60, 18, 31, 33. These are the ones that have viral oncogenes. Now, what is E6 knockout? P53. What is E7 knockout? RB. All right, now what do you call it if you have a perihepatitis and you're looking, you see violin string adhesions between the capsule of the liver and the fallopian tube on laparoscopy? We call this Fitzhugh-Curtis, which is a perihepatitis. It's a form of pelvic inflammatory disease where it's basically infection modulated by the liver. All right, now what's the term for cervical dysplasia involving 2/3 of the thickness? Well, 2/3, that's moderate dysplasia or CIN2. 2/3 is CIN2. CN2. If it pap smears then, we call it high-grade squamous intravillus. So this is the pap smear term. This is the biopsy term. Okay, good. All right, now, what do we use during colposcopy to highlight the area of the cervix to make it white so we know to biopsy? Acetic acid. We use acetic acid on the cervix to see the areas we should biopsy. Okay, now what's the treatment for high grade, CIN2, CIN3, carcinoma in situ, and even small microinvasive squamous cell? Local therapy. Cone biopsy is usually what we do. But again, you can loop curate it, you can freeze it, you can laser it. Gotta give local therapy, gotta kill it. All right, now what's the type of polyp that has malignant potential? It's not the endocervical, it's the endometrial polyp. Look for them very closely. All right, now yellow-green frothy vaginal discharge with a strawberry cervix and organisms with corkscrew motility. It's tricky. It's tricky to corkscrew, but JJ, that way you'll get a strawberry swirl. Do you know the move from Seinfeld? Is it clockwise or counterclockwise? What's your finishing move? It's tricky. All right, now let's move into the uterus. Some important terminology here. A very frequent complaint is a woman comes in with abnormal blood coming out of the vagina, probably coming through the uterus. So this is called abnormal uterine bleeding. Some terms. Menorrhagia. What's menorrhagia? Profuse or prolonged bleeding at regular intervals. So basically, heavy periods. What do you call metrorrhagia? Well, this is irregular bleeding in between the periods. So this is called breakthrough bleeding. Okay? Now, what's oligo? Oligo means infrequent. So oligomenorrhea means bleeding at intervals that are longer than 35 days. That's a very long time. Cycles usually less time than that, right? What is amenorrhea? Well, without menses. No uterine bleeding for 6 months. That's amenorrhea. You gotta wait 6 months of no bleeding. That's amenorrhea. Now, very important. Is it primary? You've never had a cycle? Or is it secondary? Primary means it's a young girl who's never ever had a period. Never. Well, the most common cause of primary amenorrhea is going to be Turner's. Turner's. Most common cause of primary amenorrhea. Now, secondary amenorrhea means I've been cycling and then I stopped for 6 months. I haven't had a cycle for 6 months. Most common cause? Pregnancy. Always get a pregnancy test. And I'm going to approve if you want to get a pregnancy test. Quick. Pregnancy test. Now, always abnormal. You shouldn't bleed after menopause. Post-menopausal bleeding, gotta look for uterine pathology. You should be bleeding at that point. All right, now what are common causes of abnormal uterine bleeding? Well, polyps. Endometrial polyps, endocervical polyps, endometritis, inflammation of endometrium, leiomyomas, these benign smooth muscle tumors in the wall, they push on the endometrium and get bleeding. Endometrial hyperplasia can bleed, and of course, endometrial cancer. And that's the one we never want to miss. We never want to miss cancer. So these are common causes of bleeding, abnormal vaginal bleeding. Now tell me, what is abnormal vaginal bleeding? But I look for all these causes and I can't find anything. There's no leiomyoma, there's no polyps, there's no cancer, I don't find anything. Then we blame it on hormones. Gentlemen, never, ever, ever blame anything on hormones. Only women can do that. Okay? And a woman will say, all right, if I can't find anything wrong, I guess it's the hormones. So we give this a fancy term. We call this dysfunctional. The hormones imbalance. So the endometrium is shedding when it shouldn't because you don't have enough estrogen or progesterone. The cycles, the hormones are messed up. So we call this dysfunctional uterine bleeding. Basically, it's abnormal bleeding from the uterus without a structural or organic uterine pathology. Blame it on hormones only if you can't find any other reason. So this is basically a diagnosis of excluding everything else. If we exclude all this stuff, then we blame it on the hormones. Now, What's an anovulatory cycle? Well, that's when you don't ovulate. If you don't ovulate, well, think about this. I'm going to build up my endometrium, build it up, build it up, build it up. Then I'm going to ovulate. After I ovulate, if it doesn't implant, menses. Well, if I don't ovulate, I'm going to build it up, build it up, build it up. Then I ovulate. Well, then I'm going to go through, I'm going to build it up, build it up, build it up. You're going to get a thick endometrium because you didn't ovulate. You kind of skipped it. You skipped the ovulation. So that's the most common cause of dysfunctional uterine bleeding. She just skipped an ovulation. Makes sense? Because you go from proliferative to secretory, then you ovulate, then you shed. Well, if you don't ovulate, you go proliferative to secretory, to more proliferative to secretory. You're going to get a thick endometrium. It's going to bleed. Now, another one is called ovulatory dysfunctional bleeding. This is when we have an inadequate luteal phase because not enough progesterone. That's another reason you can get dysfunctional uterine bleeding. So again, think about the hormones. Think about not ovulating, and then you wind up with the thick endometrium. All right, now let's talk about some pathology here. Uterus. First thing is inflammation of the lining, the endometrial lining. We call this endometritis. Now, clinically, you're going to get a fever. You're going to get midline abdominal pain where the uterus is, and you're going to get irregular menses, irregular menses. Now, it could be acute or it could be chronic. Now, if it's acute, you're going to see acute inflammation. You're going to see neutrophils. Neutrophils, abscesses, that's acute inflammation. Now, what is it usually due to? It's usually due to pelvic inflammatory disease. It's an STD on its way up. It's gonococcus, it's chlamydia, it's pelvic inflammatory disease. Now, risk factors for it are after delivery or after miscarriage. Because after you deliver, there's often little pieces of retained placenta. Or after miscarriage, there's some little pieces of retained placenta. Well, that dead placental tissue is a culture media. So it's going to make it very high risk for bacteria to come up and start growing in the endometrium. So that's a big risk factor for getting bacteria coming up and growing. That's going to be acute endometritis. It's part of pelvic inflammatory disease. Now, if it's chronic endometritis, what inflammatory cell? You think lymphocyte, right? No. Lymphocytes are normally found in endometrium. So we have to look for a different cell. To call it chronic inflammation, you gotta look for plasma cells. Lymphocytes are normal, plasma cells should not be seen. So if you take a look here, look at this cell, kind of hard to see, but I think you can see like it's got cytoplasm with a little bit of clearing, that's a plasma cell. So again, nucleus is pushed to the side, and you got this perinuclear halo, that's a plasma cell. So again, all you really need to remember, plasma cells in the endometrium is abnormal. Lymphocytes are normal. Neutrophils is acute. Plasma cells is chronic. Now, this could be a chronic pelvic inflammatory disease. This didn't heal. But more likely, it's going to be an IUD. If you have an IUD, now what bug loves to grow on it and cause chronic inflammation? Actinomyces. Yep, sulfur granules will be seen. Actinomyces. So when you do your OBGYN rotation, you'll look like an all-star. Hey, we just took out an IUD, an implantable uterine vest. We just took it out. What should I culture it for? You say actinomyces. Do you see these sulfur granules? Look for sulfur granules on it. You'll be an all-star. So actinomyces loves to grow in IUDs and cause chronic endometritis. You'll see plasma cells in the endometrium. Okay, so here's the endometrial glands. And by the way, normal endometrium should have lots of stroma and then a gland. Lots of stroma and then a gland. So there should be like 50-50. 50% stroma in the picture, 50% glands. So if you look at this slide, it's about 50% stroma, 50% glands. This is what normal endometrium should look like. If I see more glands, that's hyperplasia. Hyperplasia, too many glands. Okay, but this is normal, about 50-50, that's what we should see in terms of normal endometrial glands to stroma ratio. All right, now what do we call it? when we have endometrial glands that go down into the myometrium, the muscle layer. What we call it, adeno means glands, meiosis means muscle. The endometrial benign glands have decided to take up shop in your muscle layer. So this is benign glands in the myometrium. So basically what's happening here is the basal layer of endometrium just starts growing down. It starts growing down into the muscle layer. So we're going to see benign appearing endometrial glands. Now this is very important because does endometrial adenocarcinomas invade the muscle? Yeah, they do too. But they're going to be atypical, malignant cells. So very important to listen to the description. Benign appearing endometrial glands and stroma within the myometrium, that's adenomyosis. Now, since it's composed of stratum basalis, these glands don't typically have cyclic bleeding. They don't bleed every month. It's more basalis. But they will give you a thick uterine wall. So look at the thickness of this wall. It's kind of, they describe it as a globular, thickened uterus. It's like a big globular mass. And if you notice, you kind of see like trabeculations here, kind of like trabeculations. That's kind of the buzzword for thick, hypertrophied muscle. With all these glands in between, the muscle gets thicker. So you tend to see this globular uterus with thickened, trabeculated wall. Whenever I see the word trabeculated, that means muscular, thick muscle bundles, think hypertrophy. That's all hypertrophy. Now tell me, if the wall is this thick, it's going to mess things up. So she's going to get irregular periods, like heavy periods. She can have dysmenorrhea, pain, because every month, this doesn't bleed much, but it might bleed a little bit, and it's going to, bleeding in the wall, it's going to hurt. So pain during the cycle. And she can also get pelvic pain right before the cycle too, because these glands may enlarge, and it'll stretch the wall and hurt. So again, adenomyosis, not a big deal, but you better recognize it. It could be a cause of regular heavy bleeding. All right, now what's it called if the endometrial glands are outside the uterus? If they're in the wall, adenomyosis. What if they're outside, in a different organ? That's called endometriosis. This is a 5-star one. They love this one. Endometriosis is the presence of normal endometrial glands and stroma, but they're in the wrong spot. They're outside the uterus. So how'd they get out of the uterus? How'd they get out? 3 theories. First theory is regurgitant flow. When a woman has menses, the endometrial glands and stroma shut off and they come out the vagina. That's the menstrual flow. Well, in some women, they may get some regurgitation, some retrograde flow. So now these glands get carried through the fallopian tube into the pelvic cavity. So this is called the regurgitant flow theory. And it's probably correct. Because if this theory is correct, what should be the most common site because the fallopian tube empties right out onto it? The ovary. And that's the most common site for endometriosis. Endometrial glands in the ovary. So this regurgitant theory may be right because it goes through the fallopian tube right onto the ovary. Now it also deposits on the ligaments, on the fallopian tube, in this pouch back here. What's this pouch behind the uterus in front of the rectum? We call it the retrouterine pouch of Douglas. That's the lowest portion of the female pelvis. So whenever this fluid, it's always going to go down there. So when that fluid is going to go down there and it's going to start growing in that retrouterine pouch. It can also grow on the anywhere in the pelvis. So it can grow on the bowel, it can grow on the omentum, and grow here in the omentum. Now, a second theory is metaplasia. The coelomic lining, that's what lines the peritoneal cavity. Coelomic lining can turn to anything. Coelomic epithelium can undergo metaplasia. So some people think it's just an area that underwent metaplasia and turned to endometrial glands. That's how you have to, it's just metaplasia. Okay, that's an interesting theory. Now, one more theory. How the heck could it get to my brain? I've seen endometriosis in the brain. Well, in that case, the endometrial glands probably got into your blood vessels. They probably spread via lymphatics or arteries and veins, and then they grew, they went to the lymph node, they started growing, they went to the brain, they started growing. So that could explain that. Now, if there's three theories, what does it mean? It means we don't know. And if there's three theories, it usually means probably more than one is right. So for some women, it might be regurgitative flow. For some women, it might be metaplasia. For other women, it might be getting in the blood vessels and spreading that way. So it's probably more than one, probably, because there's no consensus here. But I know this, wherever the endometrial glands are, well, they need to continue to grow. So how are they going to survive when they're outside of the uterus? Well, in that area, they're going to produce a lot of prostaglandin E2, and there's going to be increased production of aromatase. Aromatase will convert androgens to estrogens, and that will allow these glands to survive outside the uterus. So again, wherever they implant, they got to make a lot of prostaglandins and a lot of aromatase to continue to survive. Now, problem. What happens next month to these endometrial glands? They're going to bleed. Every month they're going to bleed. So you're going to get cyclic bleeding. So how's it going to present? Every month, you're going to get severe abdominal pain during your menses. But John, my menstrual cycle is uncomfortable already. Exactly. This often gets missed. Because how do you know if your menstrual cramps are better or worse than the woman next to you? Pain is subjective. We don't know. Sometimes when we diagnose this, we go to the woman and say, weren't your periods really bad? And she goes, yeah, they were horrible. But I thought that's the way it was. They didn't know. See, women are tough. If a man had evidence, it would be all over. We'd be out the whole month. But women suffer in silence. They just keep going. They gotta get the job done. Women are clearly the superior of the species. Sorry guys. Every month they get pain, they keep on going. Wow. So yeah, so this is often missed. Often missed. Now, under the microscope, when we biopsy these areas, we're going to see benign endometrial gland, benign stroma, and since it keeps bleeding, we're going to see hemosiderin-laden macrophages because every month it bleeds. Now, what's it going to look like on gross? It's going to look red-brown. So some people say if you put a laparoscope in, you look at it, it looks like a powder burn, like a gunshot. The powder comes out and burns your skin. So whenever I see a close gunshot, I'll see a hole in the building, and around the edges I'll see burns, powder burns. That's what it looks like. That burns. Because it's the bleeding, the old blood. Hemolyzed blood looks brown. So red-brown. Now, if it occurs in the ovary, most common site, you'll get a chocolate cyst. All this old blood will make a big old mass. It'll become a chocolate cyst of the ovary. And they give it a fancy term. Isn't this nasty? Here's the ovary. I cut it open. When you cut it open, melted Hershey's chocolate bar comes out. Look at this melted stuff. Look at the chocolate. This is called a chocolate cyst of the ovary. Now, to try to trick you, hold on one second. To try to trick you, they may call it an endometrioma. They say it's a tumor. No, it's not a tumor. It's benign endometrial glands in the wrong spot. So they call it endometrioma because it'll make it sound like a tumor. No, it's just benign glands. They're bleeding a lot, so you get this big old cyst filled with blood. Now, what is this chocolate stuff? It ain't chocolate. This is hemolyzed blood. It's old blood. Now tell me, what's the chance you get pregnant when your ovary looks like this? This is a big cause. This counts for about 50% of cases of infertility. Because this is going to be it's going to be in the ovaries and scleroderma, it's going to be in the fallopian tube and scleroderma, and the ligaments and scleroderma. It's a major cause of infertility. This and pelvic inflammatory disease, two big causes of infertility. Now, locations, it's often all over the place. But the most common site is the ovary. It often produces a big hemorrhagic chocolate cyst. But uterine ligaments are common, fallopian tubes, the pouch of Douglas, very dependent. If it's on the peritoneal cavity, it looks red-brown, we call it powder burns. When you do a laparoscope, it looks like burns. You can see it in the rectovaginal septum. Well, if it's on the rectum, that's going to give you constipation and maybe some pain during defecation. Now, clinical. This is incredibly common. Somebody you know has it. Very common in reproductive age women. and about 10% of women in the reproductive age will actually present. A lot of women will have it and just suffer with it. 10% will come in with it. And it causes about 50% of infertility. It happened to my brother. He was trying to get pregnant, and they couldn't get pregnant. And they went in, and they found out his wife had endometriosis. And so that was the reason that they were having trouble getting pregnant. So they did in vitro. So what else can it give you? Well, it's going to give you pain during the menses, so lower abdominal discomfort during the menses, pelvic pain. They call this dysmenorrhea, pain during the menses. If it's on the uterine serosa, it can give you pain during intercourse. If it's on the bladder, it can give you pain during urination. If it's on the rectum, it gives you pain on defecation. So it gives you all over the place. Now, this is something that's kind of interesting. If I have benign endometrial glands in my ovary, could they become malignant? Yeah. So you can get an endometrial cancer in your ovary. Yep. So ovarian implants of endometriosis may lead to ovarian endometrioid adenocarcinoma. That's interesting. So you can get this turning malignant on you because it's in the wrong spot. So that's pretty rare, but it happens on exams. Okay, because you don't usually see endometrial cancer in an ovary unless there's endometriosis there first. All right, now here's what it looks like. Under the microscope, this is the colon, by the way, the colon. Notice the colonic epithelium has all these crypts. And then notice, in the submucosa underneath this, is this nodule here. Well, it looks like these dilated glands, which look different than the colonic glands. Let me go closer. Here are the colonic normal epithelial glands with a lot of goblet cell. Now look at this area here. Do you notice the stroma is very, very purple? That's endometrial stroma. And then these glands are darker. These are endometrial glands. There's no goblet cells here. These are endometrial. So this is endometrial glands and stroma outside the uterus. This is endometriosis. So benign endometrial glands and stroma in an ectopic location. That's so cool. And I've seen it in the brain. I've seen it in the lung. I've seen endometriosis in the colon. I've seen it all over the place. It can happen anywhere. But again, benign. All right, now let's talk about a benign tumor of the wall. The myometrium is made of smooth muscle. So if you get a benign smooth muscle tumor of the myometrium, we call it a leiomyoma. Myo is muscle. Myoma is benign muscle tumor. Lyo is smooth muscle. So this is a benign tumor of the myometrial smooth muscle. It's very common, by the way. In reproductive age women, 30 to 50% of all women have it. And it's most common in African Americans. They tend to have multiple lesions. They have a lot of them. Now, it is a tumor. It's monoclonal. We often see rearrangements of chromosomes 6 and 12, low yield. I just want you to know it's a tumor. It does have mutations. Now, what causes it to grow? Well, the uterus and the myometrium responds to hormones. So estrogen causes it to grow. So when is it going to grow? If you get pregnant. If you get pregnant, it grows. If during oral contraceptive, it grows. At menopause, it shrinks down, regresses, becomes a calcified mass. So if you ever look at an x-ray of the abdomen of an old African American woman, you often see multiple calcified small masses. Those are old regressed leiomyomas. They're old fibroids. Some people call these fibroids because a lot of fibrosis. So these are fibroids, leiomyomas. All right, so again, it's all about hormones. Oh, by the way, if you're pregnant and this grows, it's going to push and push on the endometrial cavity and push, and what's going to happen? You know who's the baby. So this is a cause of loss of abortions. It's a cause of loss of babies. Yeah, so always look for this. When you keep having recurrent fetal loss, I keep losing babies, look for leiomyomas because they grow during the pregnancy, they push the baby out, they kill the baby. Now let's talk about what they look at grossly. They're often multiple, and they're often very firm, so we often call them fibroids. Now they're benign, so they're well circumscribed, they're gray-white, but here's the key. Thick muscle is trabeculated. So you'll see this twirling, trabeculated appearance on cut surface. Again, when I get trabeculation, thick muscle, either hypertrophy or a tumor. Okay? Now, locations are important. If it's submucosal, it's under the endometrium, what's going to push on it? You're going to get vaginal bleeding. You get infertility because you have a big mass pushing on the cavity, you can't get pregnant, and it can cause loss of feti. Now, if it's in the inside the middle of the rail, usually just causes a mass lesion, like a palpable lesion. If it's on the outside, that definitely produces a palpable mass outside the uterus. So it can be in different locations. The one that's very interesting is submucosal because it gives you vaginal bleeding, gives you infertility, and it can push on the baby, lose a baby. On the microscope, we'll see bundles of smooth muscle. We'll see areas of fibrosis, and we'll sometimes see degeneration like calcification and cells breaking down, but it's benign. And of course, there are genetic mutations, low yield. Now let's go to clinical. This is going to present usually with irregular vaginal bleeding. So heavy periods because it's pushing on endometrium. It could present as a palpable mass with like a dragon situation. Something's holding me down. You have these big old tumors. Rare cases can metastasize. Now this drives me crazy. It's a benign tumor, but I've seen it metastasize. So they call it a benign metastasizing leiomyoma. I'm like, if it metastasizes, shouldn't we call that malignant? I know it's weird, but it's one of the rare times a benign tumor will actually metastasize. One of the rare cases you ever see that. And then could it turn malignant? Yeah. Rarely it can turn malignant, but I'll be honest. Most malignant leiomyosarcomas, they arise de novo. They usually arise de novo. Because they usually arise on their own, and they usually arise post-menopausally. That's a very important distinguishing feature between a benign leiomyoma and a malignant leiomyosarcoma. Now let's look at a couple pictures. Here's the uterus. I cut it in half, so cut it in half and open. I basically opened it like it's a book. So here is the cervix down here, and the other half is up here. So here's the cervix. Do you see the endocervical canal here? See the endocervical canal? Now, this uterine cavity is supposed to be triangular shaped. Oh, it's kind of squished. It's the endometrial cavity. It was supposed to be triangular. It's kind of squished because of this submucosal leiomyoma. See it? It's pushing in and crushing the cavity. Good luck getting pregnant. It's going to cause infertility. Here's another one. This is not going to cause much problems. Here's another one on the wall. It's this one that's going to cause the problem. So again, they're multiple, well circumscribed. They're white tan. They're kind of hard to see, but they're kind of whirling. It's hard to see at this medication, but they're kind of whirling in thick trabeculation. Benign, benign, benign. Now, under the microscope, we're going to see these spindle-shaped cells. They're kind of elongated, elongated, elongated. And notice these areas of fibrosis. That's what we call them fibroids sometimes, because they're very firm of fibrosis. So elongated spindle cells, I don't see any mitosis. Very rare to see any mitosis here, because this is a benign, slow-growing tumor. Okay? Now, I want you to compare it to a leiomyosarcoma. Okay, rule number one. They occur postmenopausally. Now, nothing should grow in the uterus after menopause. After menopause, the endometrium should become atrophic. The myometrium, everything should atrophy. So if the endometrium grows, that's endometrial adenocarcinoma. If the myometrium grows after menopause, it's a leiomyosarcoma. So this is a malignant tumor of the myometrial smooth muscle. It's most common postmenopausally. It's usually single mass postmenopausal. And most cases arise de novo. It can arise from a pre-existing old leiomyoma, but most cases arise as new tumors. Now they're usually solitary, and of course they're malignant, so they're going to be hemorrhagic and necrotic. So tell me, which one of these is benign and which one of these is malignant? Okay, benign leiomyoma, hemorrhagic necrotic thing, that's a leiomyosarcoma. That's a lot. See, this is postmenopausal. These are shrinking. These are getting smaller. They're getting calcified. They're shrinking. This one's growing bleeding, causing pain, this is a malignant one. See the hemorrhage? This whole bleeding in this thing is a necrotic one. All right, now under the microscope, the tumor cells, you're gonna see necrosis, you're gonna see funny looking cells, and lots of mitosis. Lots of mitosis. Now, the better differentiate is, the better you'll do. The more anaplastic, the worse it is. Now, why don't you take a look at this picture? Compared to the last picture, there's a lot more cells, a lot more nuclei here. But notice the mitosis, mitosis, mitosis. So they're kind of a little bit more pleomorphic, more nuclei, more pleomorphic, different shapes. And look at the mitotic activity. That's a big clue to tell me this is malignant. Now the problem is if I don't get it all out, it will recur. You must get this out completely, and sarcomas will spread hematogenous. So always check the lung.
How many? I'm going to split it into two parts because some update keeps popping up on the screen when I'm not watching.